Okay, so these were in the last groups. These are the secondary deficiencies. We talked about the primaries. Remember, primaries are typically congenital, but they can sometimes be acquired. The secondary deficiencies are almost all after birth, so they almost all affect the child after it's born. When you look, so if you need a little bit of a review slide, kind of an overview, when you look at the bacterial infections, it's common with phagocytic cells, complement pathways, and B-cell systems. The virus and fungal infections are more common with T-cell deficiencies. So if you look through the list here, the primary immunodeficiency disorders, you have things like phagocytic cells, complement cells, right? Those are the innate immunity. When you look at the ones that are not the innate, but the acquired things you have to learn, you have the primary B, the primary T, and then the combined B and T. So the ones that are associated with the immune system, a lot of times you'll see those that are also the ones you catch after you're born. So when I use the word acquired right here, I'm talking about the acquired immunity, where you have to learn it, where the innate immunity would be the phagocytic and the complement. They're already there. They don't have to have specificity. And then now we're going to talk about secondary immunodeficiency disorders, things like AIDS or other factors that affect it, things that you don't want to think of as being directly related to the immune cells. It's something that's affecting the immune cells. If you learn from physiology, I don't know if other instructors push it this way, but when I really push knowing the difference between primary and secondary, primary is usually whatever the organ or the structure that's doing the work, that has something wrong with it. Like in primary hypothyroidism, it's the thyroid that's broken. Where secondary, usually it's something else that's affecting it. So it's not necessarily the white blood cell, it's something that affects the white blood cell. So maybe your white blood cells are normally healthy, but the problem is that something else is destroying them, or something else is causing a problem. So in situations like AIDS, it gets into the cell and destroys the cell. The white blood cells are healthy otherwise, but when the AIDS gets into it, it attacks it and destroys it. Or it could be something like X-ray that gets in and starts destroying your white blood cells. You take away that factor, and there's not really a problem. Unfortunately, with AIDS, you can't take away the factor. It's stuck there. It stays there. So you want to think of it like that. And I gave you the example with primary hypothyroidism being the thyroid broken. Secondary hypothyroidism might be the pituitary gland is broken. So the thyroid would be normal, but the pituitary is not telling you what to do. So it's secondary. It's outside of the actual organ or cell of focus. So here's an example with secondary deficiency. It's, like I said, usually after the child is born. But what if it's not the child? What if it's the mom that's causing the problem? So we can still refer to that as an acquired deficiency, okay? Not acquired immunity deficiencies or problems, but acquired deficiency in general. And this is a lot more common than the primary deficiencies, the things that people are born with. Like, for example, here are the three major categories, or three of the major categories, I shouldn't say all three, but pregnancy, newborns, and age. When you look at pregnancy, if the mom's immune system has a problem, it can cause a problem for the baby. What's interesting about pregnancy is that the pregnancy actually turns down mom's immune system. So it decreases it. And the whole purpose is because she has this foreign object that's growing and developing in her uterus, and you don't want her immune system to attack it. So pregnancy actually decreases the immune system. It turns down things like antibody production. It turns down T lymphocyte activity. Another one is newborns. So newborns, remember, don't have a mature immune system. Usually with newborns, their problem is that they're not getting enough from mom. Or not getting enough from mom. They're not getting it from mom anymore. So up until the first 6 months, they've kind of been depending on what mom gave them. And now their problem is that they're running out. And then the age community. So with age community, what you see most of the time is low response to vaccines. So they get vaccinated against something, but the problem is they're not responding appropriately to it. Or more immune disorders. And that's typically associated with the thymus. So you know with the thymus, it starts shrinking with age, so you see more T-cell function dysregulation or problems, like T regular cell start decreasing, so the cytotoxic T cells can get out of control. So vaccines, autoimmune, and things related to the thymus are typically what we see in the age community. Other factors, there it goes. So other factors can be things like your diet, stress, malignancies like cancers and tumors. So thinking nutrition, you need certain things in your diet. If you don't get them, then the white blood cells can't develop properly. I'm taking a nutrition class right now to broaden my nutrition horizon, and we just talked about vitamins. Like vitamin A, E, and B are actually important to make enzymes in T and B cells. So the T and the B cells, there's nothing wrong with them, they're just missing the enzymes. You give them the enzymes and you correct the problem. That's a secondary deficiency. Stress is another one. Stress has a tendency to shut down your immune system. The autonomic nervous system, like sympathetic nervous system, has a big impact on your white blood cells. The more stressed you are, the less response you get from the white blood cells. So it's kind of an interesting process. I already talked about dietary insufficiencies. Things like cancers. Stress can actually cause cancers, but cancers can cause problems that are related to secondary deficiencies in the immune system. Like when you think about cancers, think cachexia and the symptoms they have. They have decreased bone marrow activity. So if they're taking chemotherapeutics, it's going to decrease the production of the white blood cells. Take away the chemotherapeutics and the white blood cells come back. With cancer, it affects the GI, so it can actually be causing a malnutrition problem. So there's just a few examples. Let's see, what else do we have on here? Virulence factors. So how dangerous the actual infector is can have an impact on the white blood cells. And then this last one here, acquired immunodeficiency syndrome. And of course, that's the disease. The disorder, I guess. The disease itself that gives you that is the human immunovirus, so HIV. And that's what we're going to talk about now. So you need to spend a little bit of time and take some good notes on AIDS because it is a big problem and it's not going away. So we kind of put it on the back burner or taken it out of the spotlight for a while, and it just seems like it's shadowed a lot, but it hasn't gone away. It's still a big problem. So some of the things you want to know is, first, it's a viral disease. And do you remember what type of virus it is? Is it a DNA or an RNA virus? It's an RNA virus. And when I say that, what should you think about? How easy is it to make vaccines for an RNA virus? So what is it about RNA viruses that make them harder to make vaccines against? It's because they mutate so fast. Okay? So HIV, human immunodeficiency virus. And what it does is it gets into your T helper cells. So the CD4 cells, they have a CD4 receptor. The CD4 receptor is kind of a bad thing in this situation because it identifies the T helper cell. So this virus goes along, it looks for the CD4 receptor, grabs a hold of it, and pulls itself into the T helper cell. Once it's inside, you know how viruses work. They replicate, they take over the machinery, and then eventually they'll lyse or burst that cell. When you look at the incidence worldwide, about 5 million per year. In the United States, it's about 31,000 cases, new cases per year. Remember, incidence is the new cases. Prevalence, do you remember what that means? Prevalence means how many cases overall are there. So when you take incidence, you look at a specific time, like per year. When you look at prevalence, you're looking at how many people alive today have this problem, whether they've been living with it for a year or they've been living with it for 10 years. It doesn't matter. So what's interesting about prevalence is that the incidence of AIDS goes down a little bit, but the prevalence is going up. So what's that tell you? That means that there are more people living with AIDS. So AIDS is becoming more of a chronic disease, where back in the 80s, if you had AIDS, it was a terminal sentence. You were gone, and it didn't take very long. And nowadays, because we have so many treatments, we can actually postpone death. Right? So when you look at the epidemiology, it's a blood-borne pathogen, and it's growing faster in women than in men. When it originally came out, or when we originally discovered it back in the early 1980s, they called it GRID, gay-related immunodeficiency, because they found that it was primarily in the homosexual population among the homosexual men. But so people started worrying that it just affected gay men, and that's not true at all, because women can get affected by it just the same. Right? And what they find is that women, because of the way that their membranes are made, like the vaginal membranes, they're very susceptible to a virus like AIDS living in there for longer. It's not exposed to air as much. It can move through the mucus, the nice warm environment, move up into the cervix and the uterus. It can move into the abdominal cavity. It can go all over the place. So women are actually at higher risk. And then there's also infants. And another statistic I might want to jot down is that about 3/4 of infants contract AIDS from across the placenta. It's a virus. It's tinier than blood. It's tinier than an antibody. or I shouldn't say tinier than an antibody, it's a little bit bigger than an antibody. It can move right across the placenta and get into the baby and affect the baby. So 3/4 are contracted from across the placenta or during delivery, when there's a possibility that the mom's blood and the baby's blood make contact, or they can actually get it through milk. Right, so let's look at what's going on behind the scenes in AIDS. So, you know the pathogenesis, it starts as retrovirus, it starts as RNA. They call it retrovirus, not because it's old school, it's because what happens is that it starts as an RNA and it turns itself around into a DNA and then injects into the DNA of the host. So, the genetic information starts as an RNA, and I've already told you several times, those are the more dangerous ones. You can think of RNA a little bit more in this sense too, is that your cytoplasm of your cells is full of RNA. So there aren't a lot of machines that want to chop up the RNA. There are machines in there that do it, but not a lot. There are a lot of machines that are very specific for DNA, though. If they see DNA in the cytoplasm, they want to destroy it because DNA shouldn't be there. So a DNA virus actually has a lesser chance, or a reduced chance of getting into your nucleus and affecting it than an RNA virus. Because an RNA virus can sneak right through your cytoplasm, right to the nuclear wall, and then inject itself in. Right? So these RNA viruses, they have to have something that turns it around, because our cells don't have that structure that turns RNA into DNA. So the virus comes with something called a reverse transcriptase, which makes it unique. And if you say that something makes a pathogen unique, that means that's something you can target to try and kill the pathogen. If we don't have reverse transcriptase, but the virus does, if we target a medication to kill the reverse transcriptase, we have a better chance of killing the virus. Right? So it has to use this reverse transcriptase. Remember, transcription means to write. Since it's reverse, instead of writing from RNA to DNA like normal cells do, it takes it from RNA to DNA. So backwards. And then the next chemical it has is something called integrase, and this integrase helps it to integrate. And you can see down here, the integrase is going to take this new DNA and inject it into your nucleus. So if we can stop this HIV virus from binding here at the surface, actually I'll go to the next slide because the next slide has the picture. So if we can stop this this HIV virus from attaching to your CD4 cells, if we can stop it from turning its RNA into DNA, or we can stop it from integrating into the nucleus, we might have a better chance of fighting it. And the therapies that are out there are doing exactly that. So you can see this virus comes floating along, it identifies the CD4 receptor, grabs the CD4 receptor and just pulls itself on in. So it's going to open up, and when it starts opening up, it sheds its coat and just injects the RNA into you. Okay. Once it's in there, it uses its reverse transcriptase to write it from RNA into DNA. And now you have this proviral, so before the actual virus gets into your DNA structure. And then it has the integrase that can inject itself in. Once it's in your nucleus, it's going to integrate into your DNA, and now you're infected. The only way to get rid of it is to kill the whole cell. So now it takes over the machinery. It starts turning up its activity. It's going to make tons and tons of these little virions, baby viruses. I mentioned that earlier. But it's going to make tons of these baby viruses and then release them into the environment. It releases them into an environment in a coat that looks a lot like you. So it's easily hidden from you. Right? One of these special receptors is called a GP120. And this GP120 is a unique structure on the surface of HIV. So this may be one of the treatments that we can use to attack this stuff too. But the problem is mutations. There's so many mutations that happen with HIV. So when it infects one person, even within that one person, it may start changing, start mutating from the infection of one cell to the next, to the next, to the next. There's a lot of risk going on with HIV. And I already talked about this. So this GP120 is just a little protein. And that's the protein that helps identify CD4 molecules. Okay? So the problem with using that to treat it, it's kind of touchy, because if it's binding to the CD4 molecule, you may accidentally start binding to your own CD4 molecules, the treatment, and start causing problems to your own cells. Oops, I think I just forgot to mention something. There we go. So here we are, CD4 T helper cells. Typically you have about 800 to 1,000 cells per cubic millimeter. And then what happens is when it develops far enough that HIV has destroyed a lot of your white blood cells, and that white blood cell starts dropping, they refer to it as reversing the ratio. So normally you have a lot more CD4 T helper cells, and then you have very few cytotoxic T cells as a comparison. But what happens is suddenly it reverses. You have a lot of cytotoxic T cells, but not very many CD4 T helper cells to communicate with them. Right, and then this is what it looks like. So the official diagnosis, when your T helper cells drop from that 800 to 1,000 cells per cubic millimeter down to under 200, then you're diagnosed with AIDS. Up to that point, you're actually just infected with HIV. But once you have your immune cells, your T helper cells dropping under 200, suddenly you have AIDS, the actual disease. Here's one of the trickier, touchy things you really want to put a note down on, is that how someone contracts HIV can affect how soon you can identify it. If somebody contracts by blood exposure, you'll start seeing antibody response from your immune system within about 4 to 7 weeks, which is way longer than usual. Usually when we get an infection, within about 6 days, you'll start seeing a spike in antibodies. And then, of course, repeat exposure, it's even faster and faster and faster. But with HIV, it's kind of sneaky. So if it gets into your blood, it takes about 4 to 7 weeks for you to actually be able to take a sample of that person's blood and see antibody present against HIV. If they get it from sexual contact, it typically takes 6 to 14 months. So they've had this virus inside of them for 6 to 14 months before you can even identify it with a blood test. Right? So that kind of puts a lot of risk out there. Just because they're not showing positive antibodies doesn't mean they don't have the virus, and doesn't mean the virus is spreading. So they could be contagious during that whole time that they're showing as being HIV negative. And what we feel is that there's probably about one person diagnosed for every 100 people that are infected with HIV. So it's kind of a sneaky disease, and we just don't know exactly what's going on out there. And then when you're looking at this diagnosis for HIV to become AIDS, it typically takes about 10 years before their white blood cells drop down to this 200 cells per millimeter. Oops, I think I got everything back here. Yep. So the next, Kaposi sarcoma. And Kaposi sarcoma is a human herpes virus, and it's HHV8. This is very, very common with HIV. So the HHV, human herpes virus, number 8, likes to tag along with HIV. And what they find is what happens is this thing gets inside of the person that has HIV, and their immune system's down, so this virus can go crazy. And what it does is it goes into the person and it starts causing problems with the vasculature, like the capillaries. So the capillaries are weak, they're not holding their shape very well, and then what you see are all these little tiny bruise-like structures. Okay. So it starts with little things called petechiae, and then they become larger and larger, and it looks like little tiny bruises all over. And what's happened is the blood capillaries have popped. The blood's seeping out here and not being returned, and then it looks like a bruise because it's just deoxygenated blood puddles underneath their skin. Let's see, and then Kaposi sarcoma doesn't actually cause the death itself, it just weakens everything. Right. And then treatment and prevention, this is for HIV again. Like I said, we know these different steps that it takes for HIV to infect the cell. We understand, but it changes so fast that it's really hard for us to attack it. The best things we can do right now are we look at the areas of weakness. So we know that it needs reverse transcriptase, and it's something unique to the virus, so we'll make a chemical that attacks that. We know that it needs protease, which is an enzyme, to help cause the chain reactions to change things. So we can inhibit that too. We know that it needs something to bind and get in, so maybe we can give it some kind of an entrance inhibitor, preventing it from getting in. And then maybe we can find something, since it has to be integrated into your DNA, maybe we can find something that inhibits the integration. So those are the different areas that they're focusing on right now. And this HAART, this highly active antiretroviral therapy, kind of focuses on 2 to 3 of these at any time. And it's constantly having to change a little bit because we don't understand exactly all the mutations. There are so many genes that could be, or genes, so many little structures that could be mutated. So we can focus on different ones. So kind of a question for you, and there's no little guy, so you don't have to write it down, but what's the name of the cell and the receptor that HIV has an affinity for? So what was the name of the receptor? And I'm not looking for the GP120. The GP120 is a structure that detects the receptor, and the receptor was a CD4. The name of the cell that holds the CD4 receptor was B or T cells. It's T cells. Was it cytotoxic, a regulatory, or a helper cell? It was the helpers. So it attacks the the T helper cells. And the last couple slides here, graft versus host. So GVHD, graft versus host. Imagine you're getting a transplant. And when you get a transplant, you have to have a turned down immune system. What if we give you a transplant that's full of that other person's white blood cells? That other person's white blood cells recognize that organ as its own organ. It's not going to fight the organ. But what happens when we push blood through that organ and into you? It's going to carry those white blood cells out and into your circulation. So what could potentially happen to you? It's like a Trojan horse type of situation. I introduce this organ to you that has all these soldiers inside of it. They're going to come out and they're going to start attacking you. And it's called graft versus host disease. The people that are most risk for graft versus host are people that are immunocompromised, because their immune system's already down. When you give them this new organ, the T cells jump out and they start attacking that person's body. And that person's immune system is already down, so the T cells can just go rampant. Typically, they like to attack things like the liver, the skin, and the GI mucosa. Right? So in this situation, those people have to take a lot of immunosuppressants to make sure they turn not only their own immune system down, but this new immune system that got introduced to their body. When you classify as acute versus chronic, acute just basically means that they get this rejection within the first 100 days. Okay. So not just rejection, but this attack within the first 100 days. Chronic is if something delays it and it lasts for over 100 days and they're having a problem getting rid of it. When we evaluate somebody's immunity, you can do it through lots of different methods. And you've probably done this in your rotations or in a lab. But one is CBC, or complete blood count. So what they're doing is they're looking at your white blood cells. Do you have a raised level of white blood cells? And if you do, what's going on? Are they more neutrophils, more eosinophils, more basophils? We can look, do you have a decreased level of white blood cells? And if so, what's decreased? So we can look at those subpopulations. Another one is that you do a determination of the immunoglobulins, which are also known as the antibodies. So you take a little sample of your blood, they can separate out the different types of Igs. So is it IgG, A, N, E, or D? Which ones do you have an abundance of? Which ones do you have deficiency of? And then we can go back and look. If it's an Ig, what kind of deficiency would you have? Would you have a T cell deficiency, a B cell deficiency, or a complement deficiency? It would be the B cell deficiency. So we know it's going to be B cell related, and then we can subdivide it or subcategorize it and say it was related to the M's, the A's, the G's, etc. Right? And that's another thing they can do an assay, or assay is just a fancy word for saying a test for a total complement. So how much complement do you have in your system? Of course, what's the complement you really want to be familiar with? C3. And then other ways we can test are things like skin tests. So, with TB, they put the little injection of TB under your skin and they look to see if you have a response for it. They do a similar thing with HIV, but it's not a skin test. They'll take a sample of your blood and they put it in a little tiny well, basically this little structure that's lined with antibodies against HIV. And if your blood starts sticking to those linings, then they know that you have been exposed to HIV. And that's the antibody test. And of course, remember that it takes 4 to 7 weeks for that to be confirmed if you got it from blood, and it takes about 6 to 14 months if you got it through sexual transmission. Right. So how can we treat the immunodeficiencies? If it's a deficiency in something, hopefully common sense tells you just replace it. So if it's a deficiency in the bone marrow, they can do a bone marrow transplant. If it's a deficiency in one specific antibody, they can give you antibodies from somebody else. Okay? Or we can take your white blood cells out and help modify them and then put them back into you. So if you did bone marrow replacement or a transplant or even a transfusion in some situations, okay, we can do that. If it's an antibody, the antibodies are actually only effective for about 3 to 4 weeks, and you have to have it done roughly every month over and over and over again. Okay. And then gene therapy. Like I said, you can actually take tissue out of the person. You can see down here a couple examples. Here's where they do gene therapy. They can take cells from the person. They can introduce a virus to those cells, and the virus injects the missing piece into that white blood cell's DNA. they replicate that white blood cell and they inject it right back into the same person. So nice and clean and tidy. When they do gamma globulins or immunobodies, when we get those, we can actually take plasma from people. You've heard of giving blood. You've probably also heard of giving plasma. When they take plasma, they take just the liquidy part. They don't need the red blood cells. They take the liquidy part, and then what they'll do is they'll start filtering it down. They process it and process it and process it. Take out the things they don't need. They start isolating the parts that they want. So they want the IgGs. They want the IgA. What do they want from that? Okay? They separate out the IgGs, and then what they'll do is they'll basically clean them up. Just in case there's something in there that shouldn't be in there, and you can see the process going along here. So they clean them up, and then once they're all cleaned up, they hold on to them for a little bit, they freeze dry them, and then when you need it, then they release it into you. And this is kind of interesting. It says they hold it for 60 days before they even clean and process it. And for plasma, when you inject it, they usually pool about 60,000 people of plasma together at one time and clean it that way. So it's kind of an interesting process. So what they're worried about is they're worried about some kind of a bloodborne infection or allergic reaction. So if they accidentally put too many IgEs in you, or they actually accidentally put IgEs in you, you might develop this immune response. And then this is just another example of gene therapy. So you can take it out of the person, you can put it in these are little wells. I used that word a couple times. You put it in the little wells, and then you introduce the virus to it, you let it grow, and then you can take that and put it right back into the person. So kind of like that example I gave in the other one. Another way they can do it is by an inhaler. So they can take what they want. And this is a plasmid. It's a strip of DNA from like a bacteria. And then they introduce the genes they want to put in you in here. And then what they do is they reproduce those plasmids, and then you breathe it in. It gets into your respiratory system the way that viruses like to get into you. And then it gets into your bloodstream, and it integrates itself into your cells. Right? So the next type of question is, what type of person is most susceptible to graft versus host disease? And it was only a couple slides back, so I hope it's fresh in your mind, but it should be people that are immunocompromised. And this last one, if you like watching videos, I've put a link here to a video that's kind of old, but it's still interesting just the same, that introduces you to different things like viruses and fungi and bacteria and how they get in. And you can look at the other links from YouTube to see other videos too if you like. So. But that's it. I'll see you next Monday, and we're all done. Make sure you bring your questions in from these videos, and we'll start on the nervous system.